Hi everyone. Good morning to good evening, depending on where you're based. Welcome to the last legs of 6th Global Symposium organized by Health Systems Global. I am Atib Ahmed Pare, Fellow at the Center of Excellence for Gender at Bragg James Grant School of Public Health, Bragg University, and co-chair of the SHAPES Thematic Working Group of Health Systems Global. I'm going to be chairing this session, which comprises of 5 individual presentations from different contexts. This session is about power and contestation in the governance of health workforce. Governance of health workforce is considered fundamental in order for health development efforts to succeed. Issues of coordination, stewardship, and steering of health agenda in a systematic and coherent way can only be addressed with good health governance. In a similar manner, the capacity to govern the health workforce agenda in the countries for effective service delivery is crucial, especially in the context of shortages of qualified health workers. Without taking any more time, let me quickly bring in our first speaker, Ms. Mania van Reineveld, who is a social scientist focusing on health systems and policy research at the University of Western Cape, South Africa. Mania will talk about a review of the governance of human resources for health in South Africa from past 25 years. Before I pass the baton to Mania, I would request the delegates to use the live Q&A feature that should be on your screens. This feature will help you to ask live questions during the sessions, to which some of our colleagues will answer live, and then we'll also discuss them at the end of the sessions. Over to you, Mania.
Okay. Hi, so my name is Mania van Reineveld. I'm a researcher at the School of Public Health, University of the Western Cape in South Africa. And today I'll be presenting some key observations from a desktop review that we conducted on human resources for health policy and governance in South Africa over the last 25 years. I'd like to acknowledge Uta Lehman and Helen Schneider, who are the other 2 co-authors on this paper, and to note that the paper is currently under review. So we conducted this review using an iterative and multi-pronged approach, starting with the 3 main human resources for health strategic plans that have been published over the past 25 years, as well as human resources for health-related chapters of the South African Health Review, which is an annual publication that's been published since 1995, which documents and comments on the state of South Africa's health system and policy. And from there, we snowballed our search to include other key national HRH policy, evaluations, reviews, as well as annual reports of the National Department of Health. We also aligned our review process with the work of a ministerial task team that was responsible for developing the latest HRH strategic plan, a process that's been going on in the National Department of Health for the past year after the lapse of the previous policy in 2017. So our review mapped HRH policy developments onto a timeline showing specific HRH policy, that's the yellow blocks, legislation, that's the blue, evaluations and reviews, that's the pink, and other important health-related policies in green between 1994 and 2019. And for every entry on the timeline, we also then developed an annotated bibliography of each entry so that we could map a kind of chronological view of the HRH landscape over time. For those who are unfamiliar with the South African HR landscape, we have a mix of established professional cadres, with nurses being by far the biggest group. We also have a large number of community health workers and some mid-level cadres, for example, clinical associates and pharmacy assistants. These are introduced in the early 2000s, but there have been many challenges regarding their funding and effective deployment and regulatory issues around their scope of practice. And then, although South Africa has higher than average numbers of health workers compared to the rest of, or to other countries on the continent, it still faces a health worker shortage, which is expected to reach crisis levels by 2025. So analysis from models from the most recent HR plan released a week ago suggests shortages of between 88 and 97,000 health workers. So these shortages are then exacerbated by other issues, in particular maldistribution between the public and private sector, very poor rural retention, unsatisfactory working conditions and fractious labor relations, and then poor alignment of health professional education and training with projected need also stands out as a problem. So in our paper, we chose to home in on the governance function of HRH in order to deepen our analysis of this longitudinal view. And we drew on work done for the WHO Africa region by Chw Embeddedness as well as Afriya et al. To develop a conceptual framework of governance functions. So this framework takes HRH governance as the overarching concept and then understands it as mediated through national level HRH structures and systems design. We suggest that the governance function requires capacitated, well-functioning HRH units within ministries of health, which then set up and operationalize comprehensive HRH policy and strategic plans for health workforce developments, but that these should not focus only on the development of strategic plans, but also be enabled to perform a governance function through an appropriate structure and stature of the unit within the Ministry of Health, through strong coordination with regulatory structures and professional councils, inter and intra-sectoral coalition building across levels of government and departments, and then access to and coordination of good quality health workforce intelligence for decision-making through routine data collection, as well as monitoring and evaluation. And that all of this needs to be underpinned by a recognition of the need for explicit political support, leadership, and a large degree of relational and actor management, which is what we define as stewardship. So the sometimes intangible software component of governance and a cross-cutting kind of stewardship function that acts as the glue holding all the other planning and implementation functions together. From our review, what we observed is that much of the weak governance function in HRH can be attributed to a legacy of fragmented and disease-oriented health system, with a 25-year period beginning with radical reforms towards like a democratically organized health system with primary healthcare approach underpinned by the Alma Ata, but then that this is interrupted and really marked by the HIV era of the late 90s and early 2000s, which called for the entire health system to be focused on tackling this rapidly unfolding and catastrophic epidemic, and that the legacy of this fragmentation is still present today in the way in which budgetary programs are organized and funding streams and conditional grants are couched in single focus issues. It is also clear from the timeline that for the most part, the role of evaluations and reviews of policy intervention has been an ad hoc and reactive one, responding to crises rather than tackling the underlying systemic changes that are needed and that require exhaustive and long-term planning to build continuity between interventions and between 5-year plans. And telling of this is the fact that there's yet to be a comprehensive evaluation of any of the previous HRH strategies, or evaluations of the impact of significant interventions such as the occupation-specific dispensations, which was a resource-intensive intervention aimed to financially incentivize healthcare workers, but hasn't had any real evaluation as to its effectiveness. And additionally, from looking at the mapping of evaluations, it's clear that where evaluations are undertaken, they're rarely followed by decisive policy action. So in conclusion, as we all know, human resources for health is a fundamental building block of the health system, yet it is often under-prioritized, and having a good 5-year strategic plan alone is not enough to actually shift sort of long-term systemic issues around HRH. And there is a definite need for renewal and clarification of the HRH governance priorities at national level, and a need for re-energized leadership and stewardship of this function. Strengthening the stature and structure of the HRH units across all levels of government will require explicit political support, as well as a concerted effort to capacitate the coordinating bodies responsible for stakeholder engagement. And as mentioned earlier, a much improved information system with consistent monitoring and evaluation with a long-term view. And then finally, these changes will be critical to imminent health systems reforms going on in South Africa with the introduction of national health insurance. Another thing to mention is that the COVID-19 pandemic has, of course, placed significant strain on the health system while simultaneously highlighting health workers as essential workers, especially frontline staff such as nurses and community health workers. And the lasting effects of COVID-19, as well as our move towards NHI, calls for significant strengthening of HRH governance and stewardship of the people function that lies at the heart of the health system. So I'll end there, and thank you for listening to the presentation.
Thank you so much, Mania. That was a wonderful presentation. I'm encouraging all of our delegates who are with us this evening to please use the live Q&A feature that should be on your screens. So next in line is my colleague and a good friend of mine, Dr. Stephanie M. Top, who is an associate professor at the James Cook University and the ex-chair of the SHAPES Thematic Working Group, and now the board member of the Health Systems Global. Stephanie will talk about how the governance of Australia's Aboriginal and Torres Strait Islander health workers is failing. Over to you, Steph.
Thank you for the opportunity to present this work on the governance of Aboriginal and Torres Strait Islander health workers on behalf of my team. I would first like to start by acknowledging the traditional owners of the lands on which I live and work, and pay respects to their elders, past, present, and future. So Aboriginal and Torres Strait Islander health workers are a distinctive cadre of health professionals in the Australian system. This is the only health professional role which has as one of its requirements that the individual identify as Aboriginal or Torres Strait Islander. While there are comparatively few of these health workers nationwide, around 1,300, they play a disproportionately important role in the delivery of health services in Australia's rural and remote northern areas, where proportionally Indigenous people make up a larger percentage of the population. The rationale for this project arose from a desk review of Aboriginal and Torres Strait Islander health policy and recognition that Aboriginal and Torres Strait Islander health professionals, of which these health workers make up the largest proportion, are given a central place with high expectations placed on them being able to contribute to closing the substantial gap between health outcomes of Indigenous and non-Indigenous Australians. Set against that backdrop, we were interested to understand how the role of Aboriginal and Torres Strait Islander health workers are being governed, and whether that governance is supporting and enabling those health workers to contribute to closing the gap in ways that our policy documents suggest they should. We designed a qualitative case-based study, and alongside a comprehensive document review, we conducted interviews with 51 health workers, 19 non-Indigenous clinical professionals, 8 Aboriginal and Torres Strait Islander community members, and 5 key informants. We adopted a very basic institutional governance framework, recognising that governance is not simply a top-down phenomenon, but the product of multiple factors, which can be broadly grouped into 4 domains: the regulatory environment, the organisational environment, which includes organisational hierarchy, but also day-to-day workplace practices and norms, the social environment and cultural forces, and of course, individual factors, including our motivation for working, our educational background, and so forth. Together, these factors interact and guide the behaviours of people in a health service or health system. And the product of all these things together make up the de facto governance of that system. So in my remaining time, I want to provide a brief overview of the findings, and you'll see we've split them according to those 4 governance domains that I just mentioned. First, I want to talk about the individual features of the Aboriginal and Torres Strait Islander health worker role. And the reason is arguably this role is one of the most complex in our modern health service, being as it is a composite of 3 critical sets of tasks: cultural brokerage, health promotion, and clinical service extender. But where things become complicated is that no one health worker role looks exactly like any other. As a general rule of thumb, the further north and the more remote that we got, the more we found that the role included an emphasis on clinical service delivery, since those health workers were often the only or one of the only permanent staff members in the most remote of health services and had to be capable of a range of sophisticated tasks. But in any given service, there were differing emphases on those three sets of activities from role to role. As I'll come to in a minute, this differing emphasis on the role from clinic to clinic does have some serious implications in terms of how it is understood by others and the way that they respond as a result. The second domain I want to touch on is the regulatory environment. So with regards to the career pathway, unlike nurses, midwives, medical doctors, and allied health professionals such as physiotherapists and occupational therapists, each of whom have their own named career pathway within the Queensland State Health career structure, Aboriginal and Torres Strait Islander health workers do not. They, despite being health professionals in their own right, are grouped together with cleaners in a stream called the operational, or colloquially the 00 stream. The implications of this, other than the implied insult, is that when it comes to enterprise agreement negotiations, requests for professional benefits that are necessary to support the sort of remote and rural area practice that many health workers engage in is very difficult. Similarly, movement between the levels of the career structure is not automatically linked to qualification level, but instead dependent on the opening up of a higher level position by an administrative manager. That means that we encountered a number of bachelor and diploma qualified health workers who were actually working in comparatively lower level positions, not only not being recognised for their qualifications and skills, but because those lower level roles had a reduced scope of practice, actually progressively de-skilling because of lack of practice. The third domain is that of the organisational environment. So remembering back to my description of the often fluid nature of the health worker role, our interviews really highlighted how the combination of poor understanding of the health worker role by non-health workers, combined with a very common phenomenon in modern health systems, which is risk aversion, was combining to make the management of health workers by their clinic managers often quite punitive. A key consequence of this was that almost to a man and woman, health workers talked about a sense of lack of recognition, both within their localised clinic, but also within the broader system. Difficulties recruiting and retaining health workers also meant that new recruits increasingly finding themselves without access to a senior Aboriginal and Torres Strait Islander health worker to mentor them and feeling lonely and isolated as a result. The final domain then was social and cultural forces, and related to the issue of the ageing workforce that I just mentioned, a key message coming not only from the Aboriginal and Torres Strait Islander health workers, but also their non-Indigenous clinical colleagues, was the urgent need for more health workers due to their important role in both health promotion and brokerage in response to the non-communicable disease epidemic that we're experiencing in Northern Australia. A second theme was the need to address the stress and the emotional labour of the role that requires Aboriginal and Torres Strait Islander health workers to constantly manage relationships between close family and community members and the health service with little, if any, support or protection. And the cumulative trauma of this, as this quote demonstrates, really can be quite devastating. So coming back to our 4 domains of governance, the rhetoric of governance for Aboriginal and Torres Strait Islander health workers in Queensland is that we have a well-integrated career structure, professional recognition and support, all with the idea of increasing an Indigenous health workforce that delivers culturally safe and strong primary health care, that can address the root causes of health while building trust in services, all of which contributes to closing that gap. But the reality we found from our interviews was an out-of-date career structure with a lack of corporate support, weak professional recognition, declining peer-to-peer mentorship, decreasing opportunities to practice as clinical extenders or health promotion agents, linked to the punitive management that I mentioned, decreasing opportunities also for community outreach, high levels of stress and trauma, which mean that the high burden of chronic disease and mental health and substance abuse issues in our region are not being addressed in the way they might be by this critical cadre of health workers. And as this one participant said, they tell us to close the gap. They put us through all this training. We got trained to better our skills. So what's happening? So just finally, some of these challenges of integrating a cadre of community health workers effectively into a mainstream health system are not unique. And there are lessons to be learned, I think, from the international experiences of the same, including a better understanding of the way race and racism underpin some of the phenomenon that I've described. But as part of the next phase, we're working with the Queensland Department of Health and the District Hospital and Health Service on strategies to address these structural issues. With thanks to all of our study participants, and I would welcome any questions. Thank you.
Wonderful, Steph. That was a wonderful presentation. So next we have with us is Dr. Gustavo Nigenda, who is a professor at the National University Autonomous of Mexico. Nigenda will talk about state regulatory power and the professionalization of nursing in Mexico, consequences for health services production. Over to you, Gustavo.
Good morning and good afternoon to all our digital audience over the world. We are going to present a paper called State Regulatory Power and the Professionalization of Nursing in Mexico, Consequences for Health Services Production, by Patricia Aristizabal and Gustavo Nigenda from the National Autonomous University of Mexico. Background information about nursing in Mexico. It's important to say that in Mexico we still have 3 levels of training for nurses: ancillary, technical, and university training. University training started 50 years ago, and only in 2000 we started with postgraduate training. We have identified an increase in the labor market of university graduates that traditionally has been dominated by technical nurses. We have also identified an increasing level of underemployment, unemployment, and precarious work. We have identified in Mexico a limited regulatory framework where the state is the major regulatory actor. All these issues are moving towards a professionalization process for nursing in the country. Our conceptual framework is based on one statement that says that professional regulation could be understood as a dynamic frame in which professional norms that work for public protection could be identified. Regulatory systems should be focused, flexible, and enabling to guarantee that standards are clear, visible, and reachable. We also have part of our conceptual framework is based on Moran and Wood, which identifies 4 major dimensions for regulatory structure of health professions. One is the market entry mechanisms. A second one is control for competition. A third one, payment mechanism. And a fourth one, labor market structure. We carried out a study based on a case study on nursing in Mexico through 3 phases that were completed through a documentary review. The second, the revision of secondary care, mainly based on the 2 major surveys in the country, one that collects information for all workers, and the second one that collects information particularly for nurses, and specifically on training and labor issues. And we also carried out a series of interviews with top decision makers, with frontline workers and directors of School of Nursing. Our result, based on the theoretical framework by Moran and Wood, is showing us that regarding market entry mechanisms, there is a low implementation of licensing process. We identify some cases in which students without a degree were hired both by public and private institutions, meaning that the enforcement of licensing is very weak in Mexico. Regarding control of competition, the legislation is scarce. There is a low autonomy of practice by nursing and subordination to medical hierarchy, particularly in public institutions. Regarding payment mechanism, we identify a compacted salary because the majority of nurses in Mexico are salaried, but the salary is divided in a portion that there is a deduction to pay for pensions, and there is another portion of the salary that is not, there is no deduction for related to pensions, but is seen more as an incentive type of payment. This payment is not based on performance, although some performance indicators are measured permanently for nurses, such as productivity and quality of care, but they are not linked up to the payment mechanism. Regarding market structure, the labor market of nursing in Mexico reflects very clearly the segmented structure of the health system, where different institutions have different policies regarding the recruitment of nurses. Some are preferring technical nurses and some other university-trained nurses. So we identify three main challenges for regulation in the future. One is the mass production of university-trained nurses, and its increase in the labor market is clearly calling for regulatory policy that would let us identify how many nurses we will need in the future and what kind of training should be provided. A second, regarding the clear decay of protected labor conditions that need to be restored somehow, and the loss of nurses of the nursing labor market due to unemployment and underemployment. On the positive side, we have seen also an opening of new areas of practice for nurses, particularly wound clinics, catheter clinics, and home care, as well as task shifting in medical and obstetric areas, where nurses are having increasing performance, as well as in drug prescriptions. All these areas have clear consequences for the future production of health services in Mexico. And we think that the increase of nursing participation in the country can make a difference in terms of the coverage and the quality of care of the production of services for people in Mexico. Thank you very much.
Thanks, Gustavo, for this wonderful presentation. And indeed, there has been increased emphasis globally on nurses' involvement in the health policy and systems development. But at the same time, there has been limited scholarly attention on nurses' participation in the policy making. So your article is definitely going to be added in the global pool and is definitely going to contribute globally. So next in line, we have with us my colleague, Dr. Marta Schaff, who is an independent consultant. She will talk about community health workers' voice, power, and the right to health, a critical interpretive synthesis. Over to you, Marta. Best of luck.
Hello, everyone. I'm going to present a critical interpretive synthesis of community health workers, or CHWs, and accountability. CHW programs are one approach for governments to fulfill the right to health, but such fulfillment depends on the accountability ecosystem, both formal and informal, within which CHWs work. By formal, I'm referring to the rules and supervisory structures in CHW programs, and by informal, I'm referring to political concerns, social and cultural norms, and other unwritten norms that shape to whom CHWs are accountable and for what. In some contexts, CHWs have an explicit mandate to be agents of downward accountability, meaning that they are expected to improve health system accountability to communities they serve by delivering services and by representing community concerns to the local health facility. Despite the fact that governmental CHW programs generally entail the expectation that CHWs foster health system accountability to the community. An accountability lens has not been widely applied to studies on CHWs. Thus, our review was intended to synthesize the existing literature and propose several possible research directions. We conducted the literature in 2 key phases, the first being a traditional scoping review type keyword search of several databases, and the second was mini reviews on themes we identified in phase 1, such as gender in CHWs or remuneration in CHWs. We had 2 key research questions. What factors promote or undermine CHWs as accountability agents, and can these factors be intentionally fostered to impel health system accountability? We identified 3 key types of bridging functions. These often overlap in CHW job descriptions as well as in reality. CHWs are often simply used to deliver health services to community members who would otherwise not have access, thereby functioning as a service extender. In contexts where program planners are trying to address cultural differences or mistrust, CHWs may be expected to fulfill a cultural broker role. Cultural brokers may communicate health system priorities and information to communities in culturally appropriate and acceptable ways, and communicate community needs and concerns to a health system that suffers from cultural inaccessibility, such as by providing translation, for example. However, we found little evidence that cultural brokers affect any change in the health system more broadly. Studies found little evidence that CHWs working as cultural brokers actually influence health service priorities or research allocations. Thirdly, more expansive conceptualizations describe CHWs as agents of social change or liberators who advocate on behalf of their communities on topics relating to healthcare access, quality, and the social determinants of health. The concept of the social change agent is integral to the explicit program theory and the formal mandate of many CHW programs. But unsurprisingly, this is the function for which we found the most limited evidence. The table at right lists a series of factors we identified that may shape the CHW role in the accountability ecosystem. In other words, to what extent CHWs fill the roles listed at left in a way that promotes health system accountability to communities. I don't have time to go through all of them, but one example is that the type of political regime matters. In top-down presidentialist regimes, CHWs may function as an arm of the state, ensuring that people are accountable to the government and not the other way around by practicing certain health behaviors. Another example is CHW embeddedness. On the one hand, CHWs who are similar to those they serve in ways they're like other community members, may mean that they're more trusted and better able to communicate. But on the other hand, we also found evidence that some degree of training and professional status above and beyond what's typical for the community can engender greater community trust as communities believe that these trained cadres have something to offer. In a critical interpretive synthesis, typically one aggregates existing findings and then makes new analytic propositions. Here are 3 of ours. First is that CHWs are part of the community health system, but their function depends heavily on the type of governance at both local and national level. Here we're concerned with attributes of governance, such as decision space within the health sector, government tolerance for input and dissent, and to what extent the government's approach to development is top-down. State intent is key. The government may want the CHW program to affect transformative change, or they may want it, on the other hand, to surveil community members or something in the middle. Second is that community embeddedness is a crucial attribute of CHW ability to foment local government accountability to communities. Embeddedness does not shape CHW influence over the local health sector, but it does shape their ability to change behaviors within the community and to learn about community priorities. However, we found that the determinants of acceptability vary by context and seem to be related to community trust in the government overall. Thus, fostering embeddedness is not simple as it relates to all elements of a CHW program, ranging from funding, scope of practice, training, and inbuilt mechanisms for interactions with other community structures, such as village health communities. Third, resources matter. The local health system is generally responsible for providing CHWs with supervision and payment, competently and respectfully receiving patients that CHWs refer, facilitating CHWs' service extender and cultural broker roles, and demonstrating respect for CHWs' role. Where such support is not present, it can undercut achievement of coverage objectives, as well as community trust and respect for CHWs who, from the community's perspective, are unable to deliver. Lastly, rather than summarizing our conclusions, I thought it would be interesting to relate some of our findings to what's happening now with COVID. One of the key research gaps identified in the review was, does CHW engagement of the state as a collective actor, in other words, CHW unionization, foster stronger alliances with the populations they serve? We had few examples of CHW unionization to study when we started this review, but there has been a proliferation in the context of COVID among CHWs in countries that have larger CHW cadres. These community health workers have demanded the status of employees, more PPE, higher wages, payment of delayed wages, and health insurance, among other things. These strikes are quite visible in the context of CHWs often being lauded as being on the front lines of the fight against COVID. It will be interesting to follow these strikes and other actions and to see to what extent they're successful, and if so, if greater power, political power for CHWs shapes the extent to which they're able to fulfill a more transformative role in their communities, and indeed to what extent this is an objective that CHWs have. Thank you, and I look forward to further discussion.
Thanks, Martha. That was such a marvelous presentation, and was very pretty in a sense that you discussed the state of art there, the art of the state. I mean, definitely it elucidates the plight of the community health workers. I remember back when I was in Afghanistan, I mean, the plight of these community health workers there, God. So your article does encapsulate the various barriers that interfere with the smooth operation of community health workers. Notwithstanding the challenges, in my professional experience, I've seen that community health workers are often motivated and passionate about the work they do. There is definitely evidence to corroborate their contribution in improving the coverage of health services, and especially the maternal and neonatal indicators. All right, moving on to our next presenter, Dr. Zakaria, who is a lecturer in the Health Services Management at Nationale de Santé Publique Rabat. I hope I pronounced that right. Zakaria will talk about unraveling the role of leadership in motivation of health workers in 4 Moroccan hospitals. Before I pass the baton to Zakaria, I would like to request our delegates to use the live Q&A feature that should be on your screens. This feature will help you ask live questions during the sessions, to which some of our colleagues will answer live, and then we'll also discuss them at the end of each session, at the end of the sessions. Over to you, Zakaria. Best of luck.
Okay, I'm very pleased to share with you my research about the unraveling of the role of leadership in motivation of health workers in 4 Moroccan hospitals. As you may know, that in low-middle income countries, poor performance of health systems is often attributed to poor leadership capacities of local health managers and lack of motivation of health workers within a context characterized by organizational, hierarchical organizational culture, as well as inadequate health service capacities. In Morocco, similarly, many health sector reforms such as decentralization process, hospital reform, and quality assurance program were hampered by poor leadership of local health managers, as well as lack of motivation and organizational commitment of health workers. Yet, some islands of excellence were identified where leadership may have played a role. So this is why we reviewed the literature about leadership. And one way to look at leadership schools is to categorize them into 4 leadership streams. First of all, transactional leadership is about leaders who control the behavior of staff by using sanctions and rewards to retribute good or bad performance. Later, transformational leadership have been developed where the leader play a role model, inspire others, inspire staff. He is playing with his charismatic personality and that people follow. Recently, emerging schools of leadership have arisen, and that fits more the complexity of healthcare organization, such as engaging leadership or distributed leadership, that emphasize the importance of participative decision-making and delegating tasks to lower-level cadres. Recently, complex leadership have been developed since 2000, and it is much more about enabling staff rather than commanding and control. It's less leader-focused, and it's much more about distributing leadership and effective support to lower-level cadres. So our research objective, we aimed at to understand how, why, when, and under which condition leadership leads to better motivation and performance of health workers in former Moroccan hospitals. And this was specified in two main research questions. What are the underlying processes that link leadership to health worker motivation? And what are the organizational characteristics and contextual conditions that hamper or enable these relationships? And we draw some lessons to inform health policymakers and leadership capacity development program in Morocco. So to do this, we use the realist evaluation approach, that is a theory-driven evaluation that deals with the unpacking of the black box of leadership effectiveness. It is our intervention of interest, and how leadership has led to the emerging outcomes, which is in our case, the motivation of health workers. So the realist evaluation seeks to unravel the social and psychological mechanisms that drive the motivation of health workers for each specific health worker, administrator, doctor, nurses, and within which contextual conditions this mechanisms is triggered or catalyzed. So we followed iteratively a realist evaluation cycle that started with our research questions, then a scoping review and complexity leadership. The scoping review has led us to define an initial program theory or a detailed hypothesis about the relationship between leadership and motivation. And this guided us throughout the case study design, data collection, data analysis, and formulation of recommendation. So first of all, we explicited our initial program theory as follows. Motivational drivers of health workers are explained when the leadership styles are balanced between transactional, transformational, and distributed leadership to fit the organizational characteristics, example, organizational culture, and to fit also the individual characteristics. So the more congruent the leadership style with the organizational individual characteristics, the more autonomous the motivation of health workers. So we selected purposefully 2 high-performing hospitals and 2 poor-performing hospitals on the basis of the quality assurance program. This allowed us to test our initial program theory in different settings. So we collected data from different sources, interviews, focus group discussions, as well as observation and document review from different respondents at different levels of the organization. During the in-case study, we followed the program theory, but we were not restricted by it, and we were focused on the different components of the program theory, as well as identifying the relationship between leadership and motivation using the ICAMO tool. And we compared the different relationship across time, which corresponds to the succession of different CEOs through time. So the first case study in the high-performing hospitals led us to understand the motivation of health workers as at the individual level as catalyzed by 2 different mechanisms, where leadership laissez-faire leadership and transactional leadership were quite associated with negative outcomes, with negative motivation and low perceived supervisor support, and transformational leadership and distributed leadership were associated with better autonomy support and better perceived supervisor support. At more organizational level, the responsiveness to basic psychological needs of staff, as well as the conducive organizational culture, were an essential contextual conditions that facilitates the leadership effectiveness. So later on, we took the first refined program theory and tested in 1 high-performing hospitals and 2 poor-performing hospitals, and this led us to a refined program theory that is as follows. Complex leadership, understood as the balance between different leadership styles, can increase the motivation and human resources outcomes by increasing three mechanisms: perceived supervisor, organizational, and satisfaction and basic psychological needs, only if the contextual conditions allows it: conducive organizational culture and the absence of perceived organizational politics. So at the end, our study contributed to fill the gap in leadership studies in low middle income countries, in particular in North African countries. And we focus on the balance and the congruence between leadership styles with the organizational and individual characteristics, as well as the importance of distributed leadership in healthcare, because it fosters creativity and adaptability. Three mechanisms, as we have mentioned before, that we need to test further in further studies, and the contextual conditions that hampers leadership effectiveness are hierarchy and perceived organizational politics. At the end, as a recommendation, we suggest a multi-layered integrated framework for capacity building program that focuses first on leaders' attributes to adapt his leadership styles to different organizational and individual characteristics, as well as the balancing between these leadership styles and understanding the nature of the motivation of health workers. Finally, at organizational level, health policymakers need to create conducive organizational culture and climate that allow distributed leadership. And finally, we need to socialize health workers to have better public service motivation and integrate public service motivation in human resources policy. Thank you.
Thank you. Thank you, Zakaria. That was, again, a pretty good presentation. I'd like to thank all of our presenters, Mania, Stephanie, Gustavo, Marta, and Zakaria. This has indeed been a knowledgeful session. That is what we at Health Systems Global intend, not only to co-produce knowledge, but also facilitate sharing them across global platforms to enhance cross-learning. We have learned about the governance of health workforce structure in South Africa, Aboriginal and Torres Strait Islander health workers in Queensland, Australia, professionalization of nursing in Mexico, community health workers' power and voice, and the fact that they are the agents of social change. And lastly, we also came across the role of leadership in Moroccan context. Let's move on to our next component, which is the question and answer session. The first question goes to Mania. What is the role of monitoring in strengthening the governance of health workforce? Mania, over to you.
Thank you, Atid. Thanks for the question. And I mean, this is I think relevant across many of the presentations, but from the work that we were doing, so monitoring and whilst what we called systems intelligence is like one of the key functions that we highlight in the paper as part of the health human resources for health governance function. And I think from our findings, what is clear is that not only does there need to be sort of effective systems of monitoring and generating that kind of intelligence and data in an ongoing way, there's also a need to differentiate between the ongoing monitoring for general systems intelligence and the sort of crisis management monitoring that we see a lot of in the South African context, where evaluations come through only in response to sort of extreme failures and weaknesses, and that there isn't necessarily feedback between the two systems or a continuous engagement across them. And I think something else that I was thinking as the presentations were going on is it's one thing to implement and have strong systems for monitoring routine data around numbers and distribution, etc. But there's also certainly a need for monitoring of the more intangible elements of the system. So things like organizational culture, and many of the presenters today referred to issues around hierarchy and how those more intangible
factors that shape the experience of the human resources in a health system can be monitored over time, and where there are interventions to address those things, their impact understood. So I think that's another interesting element of the conversation around monitoring to have. But yeah, I will stop there. Thank you.
Thanks, Vania. So before moving on to the next question, let me quickly ask Zakaria, what do you think in your Moroccan context is the role of monitoring to strengthen the human resources for health? Zakaria, over to you.
Yeah, thank you. I'm very pleased with the question and the answer of Mania, which is to the point, and there is a necessity to look at the organizational climate, as she said, but also to look at tensions that are in Morocco increasing in terms of interprofessional tensions between nurses and doctors, which hampers the collaboration and care, and which is an essential barrier to a good quality of care. So if I was in a position of recommending for policymaker in human resources for health, I would recommend to look at the underlying causes that explain why there are many tensions between health professionals, and how to look forward, reducing the hierarchical organizational culture for better clan-like culture, where social cohesion is an essential component that drives health workers' performance. Thank you, Atiba.
Thank you, Zakaria. Wonderfully answered. So moving on, the next question is for Stephanie, and which is, did you come across evidence of any informal rules or power or networks leading to the persistence of discrepancy between the rhetoric and reality of policies on human resources for health and the Aboriginal and Terraces Islanders health worker programs in Australia?
Thanks for the great question. Yes, many of those things were present, and I think underpinned the discrepancies that we saw. I guess on one level, a lot of it related to the sorts of responses that Zakaria and Manya were just talking about, in terms of the very entrenched hierarchies that exist within the health system. And so we have in Australia, as many places, a medical hierarchy that places doctors at the top, sort of nurses and allied health professionals somewhere underneath that, and Aboriginal and Torres Strait Islander health workers are definitely sort of at the bottom of the pile of that medical hierarchy. But I think it's really interesting to think about why Aboriginal and Torres Strait Islander health workers are at the bottom of the pile. And there is, I think there are some other very broad social forces that reflect a conflict between the value of knowledge systems. For example, the distinctive skill set of Aboriginal and Torres Strait Islander health workers is their bringing of cultural knowledge, and the way that they can deploy that to make other types of services more acceptable, more accessible, more understandable. But that cultural knowledge has no place within the biomedical hierarchy that dominates the structure of the Australian health system. The other incredibly important force to recognise in those discrepancy is systemic racism, which is a feature of Australian society and a feature of the mainstream health systems in Australia. And these are social norms that manifest throughout our health system. And so that systemic racism, in my presentation, I think what those regulatory features, what those organizational features, and what those sociocultural features are pointing to are just all the different facets of racist social norms manifesting in different ways throughout the system. So I'll stop there. Thanks.
Again, typical Stephanie. Nice and a very precise answer. Thank you so much, Stephanie. So this is also basically a cross question. Do you want to, Mania, quickly come in and answer this question in South African context? The same question. I mean, did you come across evidence of any informal rules of power of networks leading to the persistence of discrepancy between the rhetoric and reality of policies on human resources for health? Mania.
Thanks. I mean, Stephanie responded to that with regards to the research in Australia, and that answer is really comprehensive. And I think in many ways, some of them, the issues of hierarchies and systemic racism are cross-cutting in so many contexts. They resonated with the South African experience as well, I think. I would say in relation to to my presentation, I think, so one of the things that we did was periodize the 25-year period from 1994 until 2019 into these 3 distinct periods. And what is very interesting in terms of rhetoric is how you see the ways in which the tone, the priorities, the rhetoric of the 3 human resources for health strategies of those times respond to what are basically political priorities of that time. So in the first period, it's this sort of immediately post-1994 democracy period in which there's huge reformation and restructuring of the health system according to the new constitution and the need to redress the sort of racial inequalities of this country's history. And then with the HIV epidemic arriving on the scene, that radically shifts the political rhetoric of that period. And that's seen then in the ways in which the next HRH plan is written. And then the same goes for the 3rd period we identified, which was sort of from 2010 onwards with the introduction of reforms around introducing national health insurance and universal health coverage in South Africa. And a result of that, I mean, one would say maybe that's quite an obvious thing, that policy reflects the political period of the time, but a result to the detriment, I think, of the human resource landscape in South Africa over time is a lack of continuity between policies and in implementation. And so that's also quite clear from the other elements of things that we examined in the review, including monitoring and evaluation, and things that there is often this fragmented effect as a result of what's kind of politically what is the political rhetoric of the time. Yeah, I'll stop there. Thank you.
Wonderful, wonderful. Thank you so much, Mania. So the next question has been asked to Marta. So Marta, did you, okay, in your presentation, it appeared community health workers had some direct links to political government rather than the indirect link through the prevailing hierarchy of health system. If this is the case, does it create any challenges other than what you described, Martha? And I'm also going to have Stephanie come into this at some point because she's also co-authoring the paper. Thank you. Martha, over to you first.
Thank you, Atib, and thank you also for pointing out that Steph is the second author on the CHW paper. I recorded this prior to realizing she would also be on the panel, and I rushed through the first slide, so thank you for clarifying. In terms of political connections, I think this came out in 2 key ways. First, to relate to the earlier discussion about informality, was in an informal way. So in other words, even though the process for selecting CHWs may be formally through the Ministry of Health hierarchy, there can be some kind of political interference that is leveraged. And so CHWs can, lobby particular people that they know, or it may be that the CHWs selected have some relationship to the party in power in the given location at a particular time. that wasn't something that's explored in depth in the literature that we reviewed, but it did come up as an issue. And then there's the formal way that in some systems, there's a more hybrid selection process that goes through village health committees, which may have some political representative or some other apparatus that's kind of a hybrid between the Ministry of Health system and the political structure. Thank you.
Steph, you're next. You want to take?
Sorry.
Yeah, the
Back
same
on my
question.
mute button. So I have nothing to add with respect to the review. I think Marta's summarised that really nicely. A brief reflection on an interesting distinction in the Aboriginal Torres Strait Islander health worker research that I've been doing is that there's an interesting distinction between the model of care that is in place in the Torres Strait Islands, which are these islands right off the tip of Cape York, part of Australia, but culturally very distinct, and historically their own local government area, and the Cape York Peninsula, which is part of the mainland, and historically their own local government area. And so historically, the local government area in Cape York had a very standard service model in place for the health services, in which clinics were typically managed by a DON, a director of nursing, reporting up a very standard medical hierarchy. In the Torres Strait Islands, there's a very interesting recent history over the last 2 to 3 decades in which a model of comprehensive primary healthcare, referred to as the Torres model of care, was introduced in the mid-1990s, which placed the Aboriginal Torres Strait Islander health workers of that region in the clinic management position and linked the clinics in the region directly to the council and political structures of the region. And so it gave the health workers direct access to politicians and vice versa. And the idea was to create a forum for empowerment, engagement, and multi-sectoral planning in the sort of the tenor of Alma Ata type primary healthcare. So it's a very localized example, very successful for a period until there was a shift in state government that resulted in some erosion of that model. But I'll stop there.
Thank you. Thank you so much, Steph. So the next question is for Zakaria. Were there any links between organizational politics, trust, and transparency as it affected motivation in your research? Zakaria, over to you.
Thank you. Thank you, Atif. Thank you, Abigail, for the wonderful question about perceived organizational politics. So in my research, this was an unexpected findings where in poor performing hospitals, I found out that nepotism, clientelism, and lack of trust and transparency in organizational procedures have hampered the effectiveness of leadership. In these settings or hospitals, health workers, whenever they perceive that there is some perceived organizational politics, their motivation has decreased in terms of they are no longer autonomously motivated, no longer oriented toward public service orientation, and they shift that to extrinsic motivation and private and self-interested behaviors. And there was also a mistrust in management teams in the poor performing hospitals. So I confirm that in these specific settings, perceived organizational politics was quite a mechanism that hinders the effectiveness of leadership, whether it's transactional or not, or transformational. The existence of perceived organizational politics reduces the motivation of health workers and create a clan-like culture and self-interested behaviors from health workers. Thank you. Roger, Ati.
Thanks, Zakaria. Very precise. So next question again to you, I'm afraid, which is you described that complex leadership will help in motivation of the health workforce. What would that complex leadership entail? That's for you, Zakaria.
Okay, complexity leadership is it's not a single leadership style. It's not there's no one best way to lead in healthcare organization. It is the notion behind complexity leadership is balance, is congruence between different leadership styles, whether transactional leadership, which is rewards and sanctions, and transformational leadership, vision and charisma, combined with distributed leadership. And distributed leadership is the leadership that engaged health workers in decision-making, nurses, doctors that participate in management teams, in management meeting, etc. So the combination or the balance between different leadership styles to fit different individual characteristics of health workers. I just say an example. Doctors just perceived transactional leadership as distance, as negative leadership styles, whereas administrative staff are quite comfortable with hierarchical transactional leadership. So there's no one best way to do it, but the notion of balance, congruence is at the core of the definition of complexity leadership, where contexts play a major role. Roger, to you.
Thanks a lot, Zakaria. Wonderfully described. Another question is sort of a generic question. So I'll have all the panelists, all four of us, because Gustavo is unfortunately not joining us. So to answer this, all four of us. So has any researcher engaged with the challenges of regulation of public health specialists in the evolving health systems dimension? So Steph or Martha, you want to go in first? It's a very generic question, so reiterating the question again, has any researcher engaged with the challenges of regulation of public health specialists in the evolving health systems dimension?
I have it's a great question, but unfortunately, no, I haven't. So one of my current projects is looking at the governance of public health functions in the context of COVID in this same northern region, but the focus hasn't been on the regulation of public health specialists. So with apologies, no.
Sure, Steph. Okay, so next question goes to Marta. Marta, do you want to come in for this answering this question first? The next question is also for you, so please feel free.
I was just going to say that, like Steph, I don't have any thoughts on this, but I think it's a fantastic question. The fact that it flummoxed all of us suggests that it's something to explore and to think about the public health function within HRH more broadly, which I think is often ignored.
Perfect. So the next question for you, Marta, is, community health workers work at the ground level, but they are often misappropriated and not involved in the planning of the programs. So do you think it is necessary and the time has come for us to involve the community health workers in program planning? And if so, what are your reflections and how could that be done? Marta, do you want to bring in some ideas for the table?
Also a great question. And I think we found, when we did this review, one of the things that we were trying to place kind of front and center as an unspoken or an implicit lens for our work was what the CHWs themselves wanted and what communities wanted. And we found, levels or different text. So for example, in Ethiopia, which is a more top-down system, CHWs did have a role in program planning. So they were assigned to kind of come up with a strategy for their given catchment area and present that to higher level authorities for validation and discussion. Whereas in other contexts, they're given very, concrete targets on which they should deliver. And so they have very little decision space. And one of the things that came up in the analyses of these different programs was exactly, frustration among CHWs about their inability to tailor their work to a given context, and to take particular decisions. And so this relates to the clinical or the biomedical challenges in that particular context, as well as the cultural broker role. So that if a CHW is trying to play a broker role and their job description is written, at a central level and very clear and doesn't accommodate that, then they're unable to function in that capacity. So I'm fairly certain that the WHO guidance includes some role for CHWs in priority setting and agenda setting. And I think that's from the accountability perspective, an important way that they can improve accountability is by communicating not only their preferences, but community preferences more broadly to the health system and acting as sort of a liaison that's passing information upwards as well. But in terms of, a general statement about the value of that, I would also look at the particular context and what CHWs themselves want. Because I think there's a potential for some tension insofar as CHWs in some contexts really want to focus on the professionalization and the job element of their role, looking at remuneration, clarity, benefits, and that may be their priority above and be more so than their engagement in policy and sort of strategy and policy development. I know that's kind of a mixed answer, but it was a review, so we're looking at so many different contexts. Thanks for the question.
Sure, Martha, that's why it's a reflection. Thank you so much. That's brilliant. Mania, before we close in, do you want to come in and sort of take this question? What do you think? Is it time for us to bring in the community health workers in program planning rather than they stay on the field all the time? And because they have most of the experience, I mean, they know the field, they know how programs are implemented. We sort of design programs sitting in the AC rooms, doing desk jobs, but we don't know about the field, while those are the ones who actually go from door to door and implement those programs. Do you think it is time for us to involve them in the policy making or specific to this question, designing of the programs? Mania.
I think that's such an excellent question. I think as you're asking it, I'm thinking back to the comment I think Stephanie made around what are the knowledge, like what are the spaces for recognizing different knowledge systems. And in a way, the flip side of this question is what happens when to the sort of over formalization and institutionalization of some of that knowledge when it is brought into a policymaking space, especially a policymaking space that is then contested by poor implementation or other kind of political pulls and tugs. So I think there's no simple answer to a question like that, but certainly a sort of democratization and flattening of the hierarchy around different knowledge systems is something I think in general the medical, the health system would benefit from immensely. But I would be careful about examining and curious to understand what implications there might be for bringing that kind of knowledge into a very formal policy space, and what might get lost in the process, and what opportunities might also arise. Yeah, thanks.
Thank you, Mania. And thanks to all of the presenters, Mania, Stephanie, Gustavo, Marta, and Zakaria. Like I said, this has definitely been a knowledgeful session. This is what, like I again said earlier, this is what we at Health Systems Global intend, not only to co-produce knowledge, but also to facilitate sharing of that knowledge across global performance platforms and to enhance cross-learning. So we are going to have to end this session now, and I wish there were more time, but so looking forward to see you in the forthcoming sessions. Thank you so much for joining us.